I'm Dr. Fakir Roberi, and this is Human Immunodeficiency Virus in Adults, Day 1. Nobody knows the exact origin of HIV virus, but it probably spread from non-human primates to humans in the 1900s. If you don't treat HIV, an infected person typically progresses to death over a period of 10 years. So it's a very deadly disease. And it primarily affects men who have sex with men, which we call MSM, people who inject drugs, people in prisons and closed settings, sex workers, transgender people, and of course infants of HIV positive mothers. Now it is important to keep in mind that HIV is not transmitted by air or water, with saliva, sweat, tears, or closed mouth kissing, insects or pets, or sharing toilet food or drinks. Another important thing to keep in mind is that women have been historically underrepresented in clinical studies. This is an important thing to point out in Journal Club. And in the US, about 25% of HIV infected patients are women. Let's take a look at the prevalence of HIV in the world, in the US and in California. So on the left side, we're looking at the world. On the y-axis, we're looking at the number of HIV infected people in units of millions. So you can see that in the world, about 37 million people are infected with HIV. And of course, about 185 million people have hepatitis C. Compare that to 350 million people with hepatitis B and 415 people with type 2 diabetes. Now, you can see similar patterns in the US and in California. So for example, in the US, about 1.2 million people have HIV compared to 30 million people who have been estimated to have type 2 diabetes. So, you are a lot more likely to see a patient with type 2 diabetes than you are to see a patient who has HIV or Hep C, unless, of course, if you work specifically at immunosuppression clinic, where you see specifically HIV and Hep C patients. Now, when you look at the route of transmission of HIV, you can see that in the United States specifically, about 66% of the cases are in MSM, so whether it's in the gay population or bisexual, and about 24% in heterosexual couples. And a smaller portion, about 6%, in people who inject drugs. So injection drug is actually not the major route of transmission of HIV in the United States. And of course, an overwhelming number of these cases are in men compared to women. Now, let's take a look at the HIV virus itself. The HIV virus is a retrovirus, and a unique capability of it is that it's able to integrate its DNA into the host genome. Now, generally speaking, there is HIV-1 and HIV-2. In the United States, it's predominantly HIV-1, whereas in most of Africa, you will see HIV-2, which is not common in the United States. Now, HIV-1 itself has different groups. Group M happens to be the major group of HIV-1, and group M itself will be broken into several clades. So there's clade A, B, C, etc. And when you compare HIV-1 to HIV-2, HIV-1 is more prevalent and also more pathogenic than HIV-2. Now let's take a look at the structure of the virus. So you can see that the genetic content of the virus actually codes for several proteins. And these proteins, so this at the top is just the genome of the HIV. So different genes will code for different proteins. And every protein has a crucial function for the virus. So in the structure, you can see that there are some proteins that are structural proteins, like envelope proteins. So they have a very important function when it comes to cell entry. So these proteins need to bind to the host cell. And also there are a few enzymatic proteins. So for example, one of the important ones is the RT or reverse transcriptase. There's also integrase and there's also protease. So reverse transcriptase, integrase, and protease are three of the most important enzymes of the HIV, and we actually target them with drugs. So it's important to know because the mechanism of action of some of our antiretrovirals is actually based on this. The first learning objective is describe the HIV life cycle and the mechanism of action of antiretroviral agents. HIV virus primarily affects the CD4 T cells. So CD4 T helper cells are a very important part of the immune system in the human body. So let's start here. When the virus finds a CD4 T cell, the first thing it does is that it's going to attach to the CD4 receptor. So some of those envelope proteins, they actually detect the CD4 receptor. And this process is called attachment, and we also have drugs, some drugs that will inhibit the attachment, called attachment inhibitors. Now, the binding of these envelope proteins to the CD4 receptor alone is not sufficient for cell entry. So the virus also requires co-receptors. And these co-receptors are either CCR5 or CXCR4. And this depends on the virus. So some viruses prefer CCR5 and some viruses prefer CXCR4. And this is referred to as tropism. So once the virus bonds to the CD4 receptor and the co-receptor together, then the virus will actually be able to fuse and enter the cell. This process is called fusion, and we also have some drugs that block this process, referred to as fusion inhibitors. Once the virus fuses, the content of the virus will go inside the cell. So inside we have genetic material, and we have some of those enzymes that came with the virus. So for example, reverse transcriptase is one of the important ones. And if you guys remember from the central dogma of molecular biology, the process of transcription is typically from DNA transcribing into RNA. And the reason this enzyme is called reverse transcriptase is because the material that comes with the HIV is actually in RNA form, and reverse transcriptase will convert that RNA into DNA. So it goes from RNA to DNA. So it's in reverse. And what this enzyme reverse transcriptase does is that it will use nucleotide. So natural nucleotide that are in the host cell will be utilized in order to form this DNA. So we can actually target this with two classes of drugs. One class is the nucleotide analog reverse transcriptase inhibitors. So these are basically drugs that kind of look like natural nucleotides. So the reverse transcriptase will accidentally use them and insert them into this DNA. But because they're not natural nucleotides, they won't be able to make links, and then it will interrupt the transcription. So we can have nucleotide reverse transcriptase, or NUCs for short. Another class is non-nucleotide reverse transcriptase inhibitors. These are not necessarily analogs of nucleotides, but these are molecules that actually have affinity for the reverse transcriptase. So by binding to reverse transcriptase, they will actually inhibit its function. So these are called non-nucleotide reverse transcriptase inhibitors, or non-NUCs for short. And then once this DNA is made, then it will go inside the nucleus of the host. And then another enzyme that came with the virus is integrase. And what integrase does is that it will actually integrate this new DNA from the HIV and will integrate it into the host DNA. And by doing that, it will actually make the HIV genetic material as part of the host DNA. And that's why, it's we don't currently have a cure for HIV, because its material actually gets integrated into the host DNA. Now, once this material is integrated into the host DNA, the virus doesn't have to do anything. Now, the central machinery of the host cell will actually transcribe this DNA material into RNA, and then this RNA will go and find a ribosome and translate into proteins. So these are genes from the host as well as any gene from the HIV. So if it happens to be HIV genes here, the end product is, those proteins that are required for HIV. So for example, reverse transcriptase will be made here, integrase will be made here, protease will be made here, and those envelope proteins, they will all be here, made here, and then they all assemble into a new virus which will bud and exit the cell. Now, once this new virus exits the cell, it's not mature at the beginning. So that's where protease will come in. Protease is very important for the virus because it will actually have the function of maturing that cell. So without that protease, that new HIV virus will not be able to infect other cells. So for it to become mature and then be able to infect other cells, it needs the function of protease. And because of that, we actually have a class of drugs called protease inhibitors, specifically HIV protease inhibitors that will block this process. And these HIV protease inhibitors are different than hepatitis C protease inhibitor. So do not confuse these two different classes of protease inhibitors. Let's take a look at the pathogenesis of HIV. As you know by now, the primary route of transmission is by sexual contact. So if it's through vaginal sex, you can see that this is the mucosal layer of the vagina, so the virus can easily penetrate through this layer and enter the body. Or if it's men having sex with men, in the rectal tissue, there are dendritic cells that actually have the function of surveying the system, and this dendritic cell will actually pick up the virus to hand it to the immune system to get rid of. So regardless of which route, the virus will end up in the body and will find a CD4 T cell. It can also infect macrophages, but the primary route is through CD4. And the reason it's really important to focus on the CD4 because CD4 T cells typically are either activated or in a resting phase. When a CD4 T cell is activated, that means the cell is actually converting the genetic material into protein, whereas in the resting CD4 T cell, it's actually silent, so it's not really producing any proteins from the genetic material. And the HIV can actually infect all of them. So the reason this is important is when HIV is integrated into DNA of a resting CD4 T cell, it's hard to detect it because the virus is actually inside the DNA, and because it's not actually being converted into any protein, there are no antigens, or there are no antigens to be detected by the immune system. Whereas in an activated CD4 T cell, because of these end products, the immune system can actually detect it. It can basically kill the CD4 T cells and also cause inflammation. But because of these resting CD4 T cells, whatever HIV is in there, it will actually be archived and stay in the body of the host without the body being able to get rid of. So basically, these resting CD4 cells will act as a reservoir for the HIV material. So even though the immune system continues to fight all the infected cells, and it will continue to kill the infected cells, whether there are macrophages or the activated CD4 T cells, those latently infected CD4 T cell will continue to be there, and occasionally, they become active, but they so the body can never completely get rid of them. So two things happen. As these CD4 T cells get activated, the immune system will kill them. So because of the destruction of these CD4 T cells, the CD4 T cell count will actually start to drop because some of them are dying. Another thing that happens because of the inflammation and all this immune response is that the lymphatic tissue that's responsible for making these CD4 T cells starts to die because of the inflammation and the response of them. So because of this, we get decreased production of the CD4 cells. So there are two reasons for why HIV infected patients start to have low CD4 counts. That's because of increased destruction of the activated ones and also decreased production. So this is a progressive disease. As patients get infected, there's initially acute HIV infection, which initially the immune system starts to kill all of those activated CD4 cells and infected macrophages. And then there's a period of clinical latency where, there's not a whole lot of symptoms, and a lot of these CD4 T cells are resting. And then over time, because of the CD4 cells count starts to drop, then the immune system will be weakened and eventually will be non-existent, and that's when the patient will have AIDS or acquired immunodeficiency syndrome. So not everyone infected with HIV has AIDS. It's only advanced HIV that we call AIDS, and by definition, it's, if the CD4 T cell count is less than 200, or if the CD4 T cell count is not available, then you can look at the percentage of the CD4. So if less than 14% of lymphocytes are CD4, this would be referred to as AIDS. Or even if someone has higher than 200 or higher than 14% CD4, but happens to get the AIDS defining condition, then this will be classified as AIDS. And those AIDS defining conditions are actually listed here for your reference. So here's the natural history of HIV infection. So on the x-axis, we're looking at time. So time 0 is at exposure, and then we're looking at the RNA levels. So you can see initially, once someone gets exposed, over a period of about 3 to 9 weeks is when acute infection actually happens. So the viral load starts to go really, really high. And, depending on the immune system of a person, so in some patients, the virus can replicate faster than in others, and it just depends on their immune system. But regardless, in the acute phase, there will be a surge of a high RNA levels in the blood, and then the immune system starts to handle it. So then the viral levels go down, and then you get the set point. At some point, the body has reached the maximum amount of killing CD4 T cells, and then also because of the damage to the lymphatic tissue, the body cannot keep up with the production of CD4 cells. So then over time, progressively, the viral level starts to go up and up and up. And to correlate this with the CD4 T cells, on the same timeline, you can see that initially a normal person has over 1,000 cells of CD4 T cells. As you can see, initially during that acute phase where there's a high level of RNA, HIV RNA, the CD4 cell starts to drop very quickly, and then the immune system will take over, and then it will be, the CD4 starts to go back up, and then at some point you reach the set point where lymphatic tissue starts to die, and then the body cannot keep up with production of CD4, and as those resting CD4 cells become active, the immune system starts to kill them. So you can see that over a few years, the CD4 count starts to drop and drop and drop. And then once it goes less than 200, that's when really, we say that the patient has AIDS, and they start to get these opportunistic infections that will kill the patient. And not just infections, but also because the immune system has the function of surveying for cancer-forming cells and destroying them. As these CD4 cells can start, these patients are also at risk of getting various types of cancer. Now, when it comes to the symptoms during the acute phase, where where there's a surge of viral load, that's when patients start to have flu-like symptoms. So typically 2 to 6 weeks after primary infections. So they're very similar to the common cold or the flu. And then, beyond that, the patients become asymptomatic until the infection actually advances. So the chronic phase is basically asymptomatic until the patient gets opportunistic infections. And then in, very advanced phases of the infection, you also see cardiovascular disease, cancer, and eventually death. Now let's take a quick look at 3 drugs that affect HIV cell entry. So we have fusion inhibitor, enfuvirtide, we have CCR5 inhibitor, maraviroc, and CD4 receptor antibody, ebalizumab, which was recently approved. We already discussed the mechanism of action of integrase inhibitors, nukes and non-nukes. So now let's take a look at cell entry inhibitors. When HIV virus binds to the CD4 receptor, it requires some conformational changes before it can bind to the co-receptors and actually fuse into the cell membrane and enter the cell. Enfuvirtide specifically binds to GP41 and it actually inhibits those conformational changes, and as a result it inhibits fusion. Ibalizumab, which was recently approved, is actually a recombinant humanized monoclonal antibody, and this antibody actually binds to CD4 extracellular domain 2, and therefore it prevents conformational changes. Now this is slightly different mechanism of action than enfuvirtide, therefore there is no cross resistance between these two drugs. And lastly, there's Maraviroc that binds to CCR5 co-receptor. So the strains of HIV that prefer to bind to CCR5 will actually be inhibited. Now it's important to note that if there are strains that actually prefer the CXCR4, Maraviroc will not work against those viruses. Therefore, it is very important to actually test, do a tropism test to make sure that the virus actually prefers CCR5 before using Maraviroc. Now in general, enfuvirtide, Maraviroc, and ibalizumab are actually reserved for patients who have resistance to other classes of HIV.